I'm Miles Himmel, Communications Director for District 5. We got San Diego County Supervisor Jim Desmond, and we got a special guest today, Dr. David Katz, who's in the medical field, who's talked a lot about this coronavirus. And David, that's where I wanted to kind of start is, Doctor, where are you on this coronavirus, and kind of give the folks some background?
Well, Miles, from the very beginning, I think what I brought to the conversation was the big picture view. I'm trained in preventive medicine, public health. My 30-year-long career mission has been adding years to lives, life to years. So unlike a lot of experts involved in the pandemic response, I wasn't looking through a very specific tunnel. Some of my colleagues are experts in virology or microbiology or pandemic response, and I very much respect that. But I'm equally interested in what we call the social determinants of health. What happens to people's health because of employment and poverty and food insecurity. So from the start, as we were looking at data coming from China and then South Korea, it was very clear to me that SARS-CoV-2, the bug that causes all this trouble, was not a one-size-fits-all threat. It's a very dangerous infection for elderly people and for people with serious chronic illness, but overwhelmingly appeared to be a fairly mild infection for young, healthy people. No guarantee of that in any individual, but most of the time. And we now have lots of data from the US to confirm the same thing. So I was worried really right from the start that, well, if we shut everything down, we've got two problems. First, we may be trying to do so much for so many that we fail to protect the people who most need protection: nursing home residents, frail elderly. And that sadly is the case. More than 50% of the deaths in this country have just been in nursing homes. And the other concern was some of these people don't need that protection. They're not really at very significant risk from the virus, and they're more likely to be hurt because of losing their job, losing their livelihood, struggling to put food on the table, destitution, desperation, food insecurity, and all the things that result when people are desperate and hungry. Depression, addiction, domestic violence, suicide, and sadly, we've seen surges in all of those as well. So my goal was, and this was basically the campaign we put forward, total harm minimization. Let's look both ways before crossing the pandemic. The virus can hurt people, but so can haphazard interdictions. Let's minimize the harms of both. And it seemed to me and many other experts that I was privileged to work with right along that the best way to do that is what we call vertical interdiction, or a risk stratified approach. Identify the different risk tiers, protect those that need protection, and let those who don't need protection from the virus keep on keeping on.
Well, one of the things, Doctor, I'm not a medical person at all, is that I'm a numbers person. I like to look at numbers and see what they are, but you can't. We seem to be focusing on one number. First it was a number of deaths, and then it's hospitalizations, and now it's just cases, cases, cases. And it seems that we focus so much on cases, but our average age right now in San Diego County is, I think, 37 years old for those testing positive. Our deaths, unfortunately, have stayed at 78 years old. I mean, that are for people that are dying. But we seem to be focusing on cases where, to me, the whole picture, you have to look at the risks involved, and the rate of people dying, and the rate of people going to the hospital based on the number of cases. So to me, you have to look at the whole picture.
I agree, Jim, and I've argued from the start for what I call the data pyramid. And by the way, we're still way behind. Even this late in the game, we're still way behind in the U.S. on knowing what is the total scope of this pandemic. And we don't need to do 10 million tests to get the answer. We need to do a representative random sample of the country. And that was doable in about, with 50,000 tests, say, in 72 hours, and it's still doable, but it hasn't been done. And the data pyramid would be how many total people have it now? Snapshot. How many people have antibodies? So what percent of the population is already through this? And by the way, a recent study suggests it's 10 times more than we've documented to date. So looking at various sites around the country, 10 times more people have already had this than the official statistics suggest. So it's not 4 million Americans who've had this infection, it's 40 million, which completely changes the rates. Then out of the people who've had this, and out of those who've made antibodies, how many had symptoms, how many needed the hospital, how many needed the ICU, and how many died? And you're absolutely right. You don't make it through week 1 of Epidemiology 101 without learning to ask, what's the denominator? You can't report a rate, the rate of death from COVID-19 without knowing how many people had COVID-19. That's the denominator. And we've never known the denominator. And I think it's massively higher than the data we have suggest. I also agree with you, Jim, about tracking. It is important to know total cases, but that's because that's the denominator. Then, how many people are being hospitalized per total number infected, and what's the distribution? So, we know that it's older people who tend to be hospitalized, people who had serious chronic illness to begin with. But if you see cases going up and you don't see hospitalization going up, what that means is it's spreading among young, healthy people who are carefully protecting their parents and grandparents. That would be a good thing, because that's how you get to herd immunity safely, is if the people who can get this get through it and not be harmed by it, make antibodies, and then they protect the rest of us who can't afford to be exposed. If you have hospitalization going up too, that means not only is the virus spreading, but it's spreading across risk groups, and that's a much more worrisome sign. And by the way, that is going on in much of the country right now, and that's because the reopening in much of the country has been mismanaged. And there wasn't basically the firewalls we need between the low risk groups, young, healthy people, and the higher risk groups who wind up filling our hospital beds.
Well, one of the big struggles we're having here in California right now is the schools. And the school,
Right.
Everybody was anticipating, sending their kids back to schools. I've had people come to, speak to me and say, hey, both my wife and I work. One of us is going to have to quit and stay at home and teach the kids and make sure that they're, if it's an online class, because that's what we're going to initially. So in San Diego County, we've had no one die under the age of 19, and actually under 20. And so, but they do get, it's still a bad disease out there. But for us to, I think we should send our kids back to school, because it's not affecting them, hardly at all. But I keep getting the pushback of, okay, if you send the kids to school, but then they go and they visit grandma and grandpa on the weekends, is that safe for grandma and grandpa, or are we introducing, or making it worse for the elderly if we have schools and if these kids are now carriers for the virus?
Yeah. So first of all, Jim, I support your point of view. I think the kids could go back to school, and I think the kids should go back to school, and for a number of reasons. One, kids are at very low risk of severe infection with COVID. And by the way, that doesn't mean zero. One of the things we have to get used to, there's been so much focus on the pandemic. It's as if, well, we can't go back to the world until the risk is zero. But, all that's required to be at some risk of dying today is living today. You don't need a pandemic to be at some risk of dying today. I mean, stuff can happen to anybody, anytime. A colleague and I, Dr. Kelly Close, she's a disaster response expert, emergency physician, and a mom. We did a piece together on Medium about addressing the return to school safely, and we cited statistics showing that actually kids are at greater risk of harm from riding the school bus than from COVID. So, the risk won't be zero. It's just very, very low. It really is. It's very low. But the question that you raise is the crucial question. So to safely let the kids go back to school. And the other thing that's important, I agree with you too, parents are how can they juggle homeschooling with the jobs they're supposed to do? So it's really difficult for the parents. It's really disruptive to people's livelihoods. And it's damaging to young children who need the social interaction to be healthy. It's psychologically damaging. All those are reasons to send them back. We do need policies in place to say, okay, how are we going to manage the interactions across the generations? It turns out, and I think everybody's heard this, kids are less likely to transmit COVID than adults, probably because their immune system fights it off so effectively. They don't get serious infection, and so they don't shed a lot of virus. So they don't transmit it very well. That's great. Older kids, though, transmit more like adults. So teens and tweens, so high school, they definitely can transmit it. So we need rules in place. So, if you're going back to school and you're interacting with classmates, and we need some monitoring, we need to keep track of the kid's temperature. There should be some testing involved. And then we ought to recommend social distancing, use of masks with older adults in their networks until we reach the point where you in San Diego County have documented there are no new cases. We've got just about zero transmission. And when there is no virus circulating, then nobody's at risk. And then we sound the all clear.
Yeah.
But between here and there, I think we do have to say if kids are mingling in school, there's risk of exposure there, probably fine because they're at very low risk. But we do need to be really careful when they intermingle with other risk groups. And I think all those policies should be in place.
Yeah. Well, I got one more, Miles, and I'll let you break in, but um, one of another, I guess, pushback that we get towards opening is, okay, and looking at rates, this is maybe more of a number thing, is our number of deaths have actually been increasing with the number of cases, not anywhere near the same rate, but they have been increasing. And they say, well, and I don't have an explanation, really for that. And so particularly in San Diego County, we have had increases and spikes in death cases, and the rate's going up a little bit, but not anywhere near the cases. So do you have any, I don't know, insight on that, or just we haven't got protections in place, or what?
Yeah, no, I think I do, Jim. I can't say for sure, and of course I'm not there. You've got a much more intimate feel for it, but my sense is, so again, I'm in the Northeast. I'm in Connecticut. So in Connecticut, in New York City, we closed the barn doors after the horses were out. It's completely clear. We locked down too late, and we were sort of waiting for a federal response that didn't come, and so the governors finally took action, and I think it was too late. And so the cases were already rising, and it was circulating. I mean, basically, the virus was riding the New York City subway, and 60% of the New York City population was probably exposed. So we had our first wave. We got through our first wave. The rest of the country was looking on and said, "Oh my, we better lock down," and they did. And the rest of the country, including California, locked down really before there was much viral circulation. Then we got through it here. Everything was looking a whole lot better, and everybody thought, okay, it's okay to open back up. But I think it was probably not done with all of the necessary protections in place for people prone to be hospitalized. So, are we carefully protecting people with diabetes, people with heart disease, people with severe obesity, along with the elderly? I mean, it's a lot of work. Pandemics are massively inconvenient things. So there's a lot of detail. I don't know that we ever did all that choreography anywhere in the country, really. And so much of the country is now really having their first wave, including, as best I can tell, much of California. And that means there has been an increase in exposure levels for older people, for people who are frail because of chronic illness. And then you would expect to see a spike, not just in cases, but also in hospitalization and in death. On the other hand, if you're seeing a really huge discrepancy, so a huge rise in cases and a relatively small spike in hospitalization and death, it means that most of the circulation of the virus is among younger, healthy people. And like everywhere else, young, healthy people, for the most part, get this, get over it, and get on with their lives. It can be unpleasant, but it's usually a fairly mild infection.
Yeah. Miles, did you have anything you want to ask?
Yeah, I want to go back to the beginning, what you said, Doctor, about, it's easy for people to see the deaths, right? Like we can comprehend that, but something that's a little harder is the loss of job and then what that means long-term, and that doesn't, so can you tactilely, can you kind of explain what that looks like, or is there a way you can kind of explain what the long-term effect?
Yeah, I think so. And Miles, to be clear, of course, I took Econ 101 as an undergraduate at Dartmouth, but I don't even play an economist on TV. So I'm a public health physician, but I really do think to fully understand the scope of a pandemic, you need multidisciplinary expertise, and I've been privileged to interact with experts in virology and microbiology and pandemic response and disasters and public health policy and economics and social determinants and all of that. So one of them in the mix is Nick Bloom, who's an economist at Stanford. We did a webinar together not too long ago. And Professor Bloom cited some literature that well known to economists, that when people are laid off around midlife for an extended period of time, on average, it shaves a year to a year and a half off their life expectancy. When we're talking about social determinants of health, these are hugely important. So a year to a year and a half off life expectancy. So in the U.S., all told, we've had more than 40 million people lose their jobs. I'm not sure what the most recent total is, but it's well above 40 million. And my understanding from the experts is that about half of that, at least, is expected to be protracted. So for extended period of time. Well, you do that math, 20 million people with long-term layoffs, And a year to a year and a half of life lost for each of those, that's 30 million years of life lost, right? 30 million person years. Okay. Now we've had 145,000 to 150,000 deaths from the virus in this country. That's terrible and tragic as well. And I've seen an estimate that on average, COVID is killing people 10 years earlier than they would otherwise have died. I actually did a stint on the front lines in New York City, and that wasn't my impression. It looked like it was mostly really elderly, very sick people who were dying of COVID, but let's say it's 10 years. Well, 10 times 150,000 is 1.5 million. It still means that there'll be 20 times as many years lost from life due to social determinants and layoffs than from the virus itself. And people need to get that in mind, that there's more than one way for the situation to hurt people. This isn't a question of lives versus dollars. This is lives versus lives, which is why I really think we should all be looking in both directions and saying we want to save as many people from the total harms of this as possible. We want to do total harm minimization. And I think that would really help us all come together on the middle path and say, what's the best way forward?
You know, I saw your article on you talked about the mismanagement. We could get in, you could spend an hour talking about every aspect of it. But one of the things is there's this tension in the United States, right? There's this, and you talked about the media. Can you kind of explain just, you know, like Supervisor was saying, there's the one number that you can put out, but I can put out this number, just kind of explain some of that if you don't mind.
Yeah, well, first of all, gentlemen, you're both raising great issues, asking great questions. I really appreciate that. And I think our conversation starts to convey that, you know, again, pandemics are massively inconvenient things. And, you know, we're sort of a clickbait soundbite society, right? So just say yes or no, go left or go right. You can't. It's much more nuanced than that. So yes, the kids should return to school, but we need to protect their grandparents. And, you know, right, it's just not so blunt as we're all in or we're all out, lock everything down or liberate my state. That, you know, the right way to manage a complex public health crisis is nuanced, and it involves a willingness to hear a range of perspectives and try and manage them. And what I was saying in that column is I think what makes this pandemic different from every other in history is not the virus, it's the internet. It's social media. It's the fact we're a highly polarized society. We actively encourage one another to, you know, basically choose a camp and lob insults at one another. That's not conducive to nuance. That's not conducive to, I need to hear your point of view. You need to hear my point of view. We actually both need to listen to one another and say, good point. I still think I'm mostly right, but you raise a good point. Yeah, I feel the same way. I still think what I'm saying is important, but I hear you. Maybe there's a way to actually combine the benefits of what we're both proposing. We're capable of that. Most of the best stuff humanity's ever done has involved teams of rivals, you know, people who don't agree about everything at the start, but listen to one another, learn from one another. We seem to have surrendered that ability for the moment. Polarized society, everything's highly politicized, things that shouldn't be. Pandemic response should not be political, right? I mean, lives are lives. And the encouragement to essentially choose your tribe in social media, gather only with people who happen to have the opinion you already owned at the start, and lob insults at everybody else before you even give them a hearing. You know, just it's really unhealthy. And I think that's what makes this pandemic unique in history. It's not the virus. It's the fact that before we can generate thoughtful public policy, we've already, you know, essentially diverged into our opposing corners and started hurling things at one another.
Well, I really appreciate your insight on this. You know, and we've been trying to, you know, look at this in a practical and how do we manage this virus, and we need to live with it. I mean, it's not going to go away entirely. And like you said, we can't really get to zero deaths. No one would get in a car, or no one, you know, we wouldn't have liquor stores. We wouldn't have,
exactly.
You know, and a lot of things out there in life, you know, but we got to learn to manage it. And I think you're right. We, you know, as long as we do it responsibly. I do like your idea earlier you said on the, you know, kind of a vertical protection, you know, the people,
right,
the elderly that are older and have, you know, underlying conditions or multiple underlying conditions, we really need to protect them. But then as we go down the pyramid, we don't need it to protect, I guess, the younger people don't need as much protection. They still need it, but maybe not as much.
Exactly. Yeah, no. And for younger people, you know, one of the things people may not realize is that use of a mask or social distancing may not completely eliminate the risk of exposure, but it reduces your exposure dose. And for any given person, whatever the health of your immune system, a smaller exposure dose means a milder infection. So that's a good thing too. So the precautions make good sense. And yeah, Miles, it sounds like you can source the materials, but I published a color-coded grid looking at population levels of risk. The other thing that's really important, Jim, and I don't think this is getting nearly the attention it deserves, I'm a past president of the American College of Lifestyle Medicine. Lifestyle is the best medicine. If we ate optimally, we were physically active, many of us, we can't change our age, but we can change our metabolic health dramatically. And many of us could slash our risk of bad COVID outcomes beginning almost immediately, beginning with our next meal or our next walk. There's really never been a better time for a Let's Get Healthy Together campaign. And then the other thing is that can be folded into this, we can actually help people understand, quantify, and manage their personal risk. And Miles, we can follow up if you like, but we at my company have been collaborating with associates who have this risk calculator. And so you can basically find out what is my personal risk for a bad outcome if I get COVID, and what can I do to lower it with lifestyle as medicine, with diet, with physical activity. I think there's a real opportunity there because, Americans, our longitudinal health is not terrific. We have very high rates of obesity, diabetes, heart disease. All of that's unnecessary. And we now have a teachable moment because everybody's saying, okay, I wasn't terribly concerned about that, but I am really concerned about COVID. Well, it's all the same fixes. So we can actually lower our risk in the short term in a way that improves our vitality for the long term. And I think maybe that's an opportunity you ought to look at.
Wow, it sounds great. It sounds like great advice for all of us, to live the healthier lifestyle. And you're right, this is a teachable moment. And whatever materials that you have, Miles, if you can get that, maybe we can help push that out to at least to San Diego County. And then if it get, whatever, I don't know if you're selling this, doctor, or not, but if it's something we can that's not proprietary that we can put out, we'd be happy to do that. So.
Excellent. Very good.
I was going to wrap it up, Jim, if
Yeah,
it works with you. Doctor, kind of last question I ask all the guests we have on is there good news coming? Is there bad news coming? What's your summation for folks as they kind of look ahead here?
So, I'm very cautious about predicting the future of pandemic. I've conferred with great experts. I would say Mike Osterholm, for example, the University of Minnesota, may be, the nation's leading expert on pandemic response. I mean, unlike me, he spent his career dealing almost exclusively with pandemics, and he's stunningly humble. You would think the world's leading expert would tell you exactly what's what. He said, I have no idea. The more I study pandemics, the less certain I am about what's going to happen, and maybe there'll be a second wave. I am cautiously optimistic, and I'll tell you why. On the Diamond Princess cruise ship, only 20% of people got infected. On the USS Theodore Roosevelt, only 20% of the sailors got infected. In New York City, 20% of the population shows antibodies. In a hard-hit province in Iran, 20%. So in populations where there was massive exposure, we see immunity develop in 20%. What that means to me is a sizable portion of the general population probably has partial native resistance to this, because coronaviruses are common. This is a new one, but there are other coronaviruses we've all been exposed to, and they may have stimulated just enough immunity that many of us with kind of casual exposures don't get sick and don't make antibodies, but we're partially immune to begin with. Then another 20% do get sick, make antibodies, and they're immune too. And we finally have evidence that some people with mild infection become immune, but not in a way we routinely measure. So that's maybe another 10%. Well, 20% plus 10% plus maybe half, that's 80%. And if 80% of us are at least partially immune, that's well above the threshold for herd immunity. I think we're there in the Northeast, and I think, for better or worse, the rest of the country is on its way. And for me, that means, after this first wave rolls over us all, this will, as Jim says, this isn't going to go away completely, but I think it will be something much more like the background noise of seasonal flu for the most part. I'm cautiously optimistic we will not have a significant second wave. We better be prepared in case I'm wrong. But to me, the case for herd immunity looks pretty good.
Fantastic. Well, Doctor, I really appreciate you coming on. Jim, any last words?
No, thank you very much, Doctor. Very enlightening, very practical, common sense, and I think the country could, do well with your message. Thank you.
Thank you. I appreciate the opportunity to share it with you. Thanks so much.